Can I just remind members, because we've had difficulties in the last number of weeks with the recording levels here, so please asking members to switch off phones completely, because they are interfering certainly with the recording equipment and the transmission of that. Apologies, I have an apology from George Robinson, Mickey Brady and Pam Cameron. Any other apologies? Okay, just one item under Chair's business. There has been a report in the media today in relation to a leaked document, allegedly from the Health Board, around the reduction in service and its impact on services in terms of funding shortages. I would seek agreement, members, that we would seek a view from given the fact that we haven't had sight of the complete document, but seek a view from the Minister in the Department as to some of the assertions that have been contained within the report.
Yeah, agreed, Chair.
Okay, thank you.
Would it be opportune to have these people that's coming today to ask them for an explanation?
Well, I mean, I think they're coming very specifically on both the programme for government and the June monitoring. I think it would be appropriate to say that we are seeking the update, but they may not be in a position to answer it today.
I know, okay.
The draft minutes from the 27th of May are on page 6 of your meeting pack. Are members content with the minutes?
Again, Chair,
Yep.
correct me if I'm wrong or if I've missed something. As I understand it, I remember last week, under any other business, I raised the committee agreed actually to record our thanks to Nicky and Charles Rainey on the successful campaign for the ILF user group, and we agreed to have it on record. Now, it's not on record. Can we get it on record?
Well, I mean, I have no issue with it being put on record, but I think the procedure is normally that it's recorded orally at the meeting. But it doesn't normally be reflected in the minute.
Well, is that the case?
I think that is normal procedure. I'm looking at the clerk for this.
It's recorded orally because
Yeah.
there's a recording of the meeting. Normally we wouldn't put anything in any other business unless there was an action agreed.
Wouldn't be happy with that because people may not necessarily, I'm sure they don't listen to the recording, but they may ask for a copy of the minutes. And that's why I would like to have seen it in writing as a copy on the minute. Not only that, but on any other thing that may be crop up, because people do seek to view the minutes of our meetings.
And was there an action coming from it? I'm trying to remember.
The committee agreed to record our thanks to Nicky and Charles Rainey for the work they done on behalf of the ILF users to bring a successful conclusion to the campaign that they were running. It was to save the ILF funding.
No, I absolutely understand that, but I'm just conscious of protocol on this one, and normally the procedure to date has been that's referenced, it's on the record in that regard, it's just not reflected on the minutes unless there is an action coming from it. Now, I'm looking to members if they're saying that they want to do something.
I certainly would like to see it recorded on a copy of the minute. I don't know what other members.
Well, can I suggest maybe members that we would write to the group for their work around the initiative and thank them for it?
Right,
Would that be okay?
Yeah.
If the committee have agreed last week that to acknowledge the work that they've played and the role that they've played, then by way of an action that can be reflected in the minute, and we can send them a note thanking them for their role in it.
Because the committee has raised it and supported it from day one. Those of us that were on the committee from day one, and it was a very successful outcome.
Okay, well, can I suggest then that that's what we do by way of an action to take that forward?
I'm happy. Thank you. Thank you. I can provide whoever it is with the address. Maybe you have them.
Yes. Okay. Okay, so item 4 is the programme for government targets, the departmental update, page 12 of your meeting pack for the relevant papers. We have departmental officials here today to brief us on progress in terms of the PFG commitments. You're very welcome, folks. Sean Holland, Chief Social Services Officer, Dr Anne Kilgallen, Deputy Chief Medical Officer, and Deborah McNeely, Deputy Secretary, Healthcare Policy Group. I'm just going to invite yourselves to make your opening comments, remarks, and then we'll open it up to comments, questions from members.
Thanks very much, Chair. Thank you for your invitation to provide an update on progress made against the HSSPS-led programme for government commitments since our last appearance before the committee on the 3rd of December last year. I will lead on commitment 61. Dr Anne Kilgallen will lead on commitments 22 and 45, and Deborah McNeely will lead on 44, 79 and 80. I'd like to begin by providing you with some background information, followed by an update on progress against the HSSPS PFG commitments. As I've said, we lead on 6 commitments which are set out for your information at tab A of the briefing paper. Commitments 22 and 45 relate to increasing investment in public health and tackling obesity. Commitment 44 is focused on providing patient education, self-management support programs for people with long-term conditions. Commitment 61 is about improving safeguarding outcomes for children and vulnerable adults. Commitment 79 focuses on improving access to new treatments and services, and Commitment 80 relates to the reconfiguring, reforming and modernising of the delivery of health and social care services to improve the quality of patient care. In line with the central framework and guidance set out by OFM-DFM, the Department has a delivery plan in place for each commitment. The most recent version of each delivery plan is included at tab C of the briefing paper. The Department monitors the progress of all of its PFG commitments and associated milestones through the normal business planning, monitoring and reporting processes. And this includes regular reports to the Departmental Board and to the Minister. Formal progress against the delivery of commitments is also monitored by the central OFM-DFM Programme for Government team. The latest progress reports relate to the position at the end of March 2015. An update for each commitment is provided at tab B of the briefing paper. The position which has been agreed by OFM-DFM is that 4 commitments, numbers 22, 44, 45 and 79, were rated as green, that is fully on track for delivery, and 2 commitments, numbers 61 and 80, were rated as green amber, that is broadly on track for delivery, with achievement with easily redeemable deviations. I'd like to bring your attention to some information in relation to the 2 commitments rated as green amber. In respect of Commitment 61, to introduce a package of measures aimed at improving safeguarding outcomes for children and vulnerable adults across Northern Ireland, although there are delays to some key actions, the Department remains on track to deliver this commitment in full. In particular, significant progress has been made on the development of the Mental Capacity Bill. Drafting of the bill was completed in March 2015, and on the 14th of May the Executive gave approval for the bill to be introduced to the Assembly with a view to gaining royal assent by the end of the current mandate. I'd also like to draw your attention to the consultation on policy guidance cooperating to safeguard children and young people in Northern Ireland, which was launched on the 19th of May 2015. The deadline for responses to this consultation is the 21st of August 2015. In respect of Commitment 80, milestones 1 and 2 have been achieved. However, the full achievement of milestone 3 in the 2014-15 timeframe was dependent on the availability of transitional funding. Failure to obtain transitional funding in monitoring rounds, combined with the financial pressures faced by the health and social care system as a whole, has resulted in it not having been possible to fund and progress all of the Transforming Your Care activities planned for 14-15. However, this commitment has been rated as green amber because the measures which have been introduced have contributed to the overall aim of the commitment, which is to reconfigure, reform and modernise the delivery of health and social care services and to improve the quality of patient care. Thank you for your attention. That concludes our opening statement. Myself and my colleagues are now happy to answer questions that you have.
Thank you, Sean. Firstly, just in relation to Commitment 80, and you tell us that Commitment 80 is green amber, which means, as you said, broadly on track for achievement with easy redeemable deviations. But we've recently heard from, for example, the Royal College of Nursing, who actually, and I'll just quote from it for the record, they made the following statement around Transforming Your Care, where they said, very few things in healthcare get the consensus that TYC got 3 years ago. Very few people said it was a bad thing. It's absolutely the right thing to do. The problem that we and patients see day in and day out is that it's not being delivered. We're very clear on that. TYC was not the first strategy document. They actually went further to say, and quite rightly in my view, to identify community care as the right way to go. It requires funding in the right place and commissioning to work better in transferring that resource from acute to community. It certainly needs a major overhaul of how things are done, and we could list more. The Donaldson's report in relation to transforming your care, the new model of care, even the comments from the Chief Medical Officer of late. So, if we're seeing things in the Donaldson report that as a result of weak communication and little action, there is substantial scepticism about transforming your care, how can we say that a target with that level of question, challenge, criticism is green amber, is broadly on track?
I think it's important when talking about transforming your care to recognise that it's almost of the order of a philosophy. When you're talking about transforming your care, you're talking about a major shift in mindset and how you deliver services. Almost a revolution, the sort of thing that could be a permanent state in terms of how you approach the delivery and planning of health and social care. With relation to the PFG commitment, however, we are talking about some specific milestones that we see as being significantly associated with transforming your care. So I don't think that it was ever intended that the delivery of the PFG commitment would be the point at which, if you delivered PFG commitment in relating to transforming your care, you would say, well, that's done, it's over. That's not the case. I think that you can make significant progress within that commitment, and in a moment Deborah will talk about that progress, without having delivered in its entirety the commitment set out in transforming your care.
But again, I go back to, given that level of questions, criticism, challenge across sectors and in the wider public, you can hand on heart say that we are broadly on track.
What I think we're saying is we're on track to deliver the PFG commitment that is associated with transforming your care. And Deborah's going to be more than happy to take you through the key elements of that, including those where we haven't made the progress that we'd hoped we would have made at this stage.
But just to be clear, the PFG commitment is milestone 3. Secure a shift from hospital-based services to community-based services, together with an appropriate shift in the share of funding in line with recommendations of transforming your care. And we're broadly on track.
I think we have to, the PFG commitment has 3 milestones on it, so broadly on track reflects all the progress in terms of the commitment right up to date. So it takes into account that milestones 1 and milestones 2 have been met and delivered. And in terms of milestone 3, there has been a significant amount of work done in relation to this, and in terms of shift left and the 83 million, we're at 44 to 45 million, so we're 50% of the way there. Over 50% of the way there in terms of that, without actually having received significant transitional funding. So, in terms of taking the 3 years, because this programme for government commitment is about 3 years' worth of activity in relation to those 3 milestones, that's why it's assessed as green amber, because it's looking at those 3 specific milestones.
Okay. See, in terms of the 44 to 45 million, you're saying that this is money that has been shifted from hospital services to community.
It was set out in the letter that went to the committee on the 20th of April.
Okay,
There's
is
the
there a
resettlement.
breakdown? Can you?
Yes, that was in the submission that went to the committee on the 20th of April.
Okay, can you give us?
Yep. In terms of the shift, the letter sent out 3 separate parts to it. It set out the shift in terms of resettlement, in terms of dementia, and that's straight from a hospital setting to a community setting. And if I can just find it in my papers. Please bear with me. In terms of the reprovision of services from a hospital into a community setting, the shift left element 28.46 million. In terms of the avoidance of hospital activity, and this is looking at 15-16, the avoidance of hospital activity, 0.57 million, and the redirection of new investment into community-based transformational services, 16.3 million. Now, it's 45 million in 15-16, but it's 44 million in 14-15, which is what the PFG commitment relates to in terms of the 14-15 year. That was in AG 187.
You see, and you've made the point, but we were told in October, Sean, that there was a sense that there was an over-reliance on monitoring, and we were given assurances in October that we could live within budget effectively. And this is now June, and we're quoting things like the process is dependent on the availability of transitional funding.
I mean, if we got money in terms of the funding provided to taking forward the transformational change, the prompt priming, the seed funding, we have depended on monitoring rounds to secure that funding. And that funding, we did get some funding for 14-15 in the October monitoring round, which meant that we were late getting off the ground in terms of spending money. And if we had got money earlier on in the year, and we got more money early in the year, we would obviously have been able to do more by way of transformational projects. But that said, in terms of the re-provision of services in community-based settings, for example, acute care at home and reablement and various other aspects, we have also put in, that's where the 16.3 million comes from, and that's funded from demography money, and that is money where it has been shifted from going into hospital settlement to the re-provision of services in a community setting, primary care setting.
But you see, I mean, I take issue with that in relation to the main budget and then the process, alongside of that in terms of monitoring rounds. But we were told, and I'll go back to that, I'll go back to the actual quote, that, I can confirm that this commitment is both achievable on the basis of the actions set out in this delivery plan, including the measures to manage risk, and affordable in terms of the funding allocated as part of the budget 2011-15 process. So now it doesn't make sense to state in a briefing paper that that milestone of the 83 million was not achieved because it's now dependent on transitional funding.
I think it was always been on record that it was always achieved, that particular milestone in terms of being achieved in full was always dependent on transitional funding. But again, I would go back to the commitment on the front of that also covers the previous 3 years, so it's talking about 3 years worth. And that's why, that's why it's amber green, and that's why it's affordable, because, in terms of what we're doing. So there has been significant shift left in terms of the 16.31 million, which has been reinvested in the re-provision of community services, and that was not transitional funding. So we have put more money outside of the monitoring rounds, but we could have done much more. In terms of transformation, if we had got more money earlier and hadn't been reliant on in-year monitoring. And in 15-16, I know we're coming to that later, we have invested already, and we're not relying on in-year monitoring to the same extent. So there's some over 16 million pounds already earmarked in budgets, in baselines, for investment in 15-16, so that we're not relying on in-year monitoring to continue, because as Sean said earlier, this is a 3 to 5 year vision. Programme for Government only is looking at this over a very short time frame, and this is to me, this is the vision, this is the way we should be working, this should be mainstream, this is what we should be doing all the time. And there's a lot of work, and the Minister's on record is indicating that there's a lot of work that's going on in the Trust day and daily, which is not linked back to a narrow TYC heading as such, and potentially not captured under TYC heading, because they are innovating in terms of delivering services every day, with the focus being on the patient. And he's on record in stating that a lot of activity also going on in those areas.
Okay, but I'll reiterate the fact that there was assurances given that we would live, and these assurances weren't only sought from this committee. I mean, the previous finance minister himself, and a number of monitoring rounds, who's now the health minister, had indicated his own views and concerns indeed around how money was spent, and an over-reliance on monitoring processes. So we're told that it's achievable, we're told that you can do it within budget, and now we're back, and that was in October, and now we're in June, and we're having a conversation back to transitional funding, and we're blaming the fact that the shift left, as we all signed up to, hasn't happened because of the availability of transitional funding.
I think, Chair, this came up when we appeared before you in December as well, and it's not a case that the shift left hasn't happened because of the absence of transitional funding. The shift left has been happening. The extent to which it has been happening has been dependent on the money that we've had available. Had we had more money, the shift would have been greater, but it's not true to say that the shift hasn't happened. Deborah's alluded to a number of areas of activity which I'm sure she would like to
To a degree of
elaborate on.
45 million.
Yeah.
Okay. Okay, there's a number of people have indicated. Kieran? First.
Yeah, Chair, I mean, that was one of my questions, just exactly what you have been covering. And it is with great concern that I think even in your application for monitoring run in the June, you're asking for another 5 million. Was that right? And that, I mean, surely that's not the way to be running the health service, by depending on what comes out, the crumbs, actually, if you like to call it, at the monitoring rounds. We should have the funding there for to do what we said we wanted to do and transforming care. The Chair has alluded to what our concerns are.
Well, I have to agree with you. You know, the department doesn't want to be relying on in-year monitoring rounds, and you'll hear later in terms of the update for the extent to which we are facing significant difficulties and continue to rely on in-year monitoring rounds, and that at this point in time, you know, we are restricted to the extent that service developments, which that would be further service developments of £5 million. Now we are continuing with the ones that we started last year, and that is consuming over £15 million of existing resources. We have £1.5 million of change fund funding, which will help in terms of TYC. So that's 16 to 16.5 million we have already in the kitty for TYC this year. That's compared to zero at this time last year. And on top of that, to do more, because we always want to do more, we're bidding for £5 million as part of the monitoring round. But obviously that's not the only pressure that we have as a department, and the department, if you know, it does not want to be relying on in-year monitoring for essential services and for essential service development.
Of course. Right, in your pack briefing paper for the programme for government commitments, I mean, it's fine, it's looking all right, but at the same time, it's not being delivered. I mean, if you look at the press in recent times about the waiting lists that were continue, they're horrendous. And I understand there's a 2-page in the Irish News this afternoon in relation to what we are not doing, providing for the health service, and the report from the audit office earlier this week is dire. You know, the health provision for our community is going from bad to worse, and we never seem to be getting any further out of the mire that we're in. Despite what you're saying in your, you know, everything's achievable. But to the people that's waiting, for instance, I had an irate constituent on it, waiting for yonks on a hip replacement, going through the home in agony, and here we are, all these fancy words, but at the end of the day, we're not providing the service that we should be.
I agree absolutely that in terms of the waiting lists, the figures are completely unacceptable.
Horrendous,
Absolutely
yes.
unacceptable. And you'll be aware that we had to stop sending additional patients to the independent sector last year,
Yes.
and that has, because of a lack of funding, and that has resulted in this situation that we're faced with today in terms of the numbers of patients waiting unacceptable times. And again, you know, when we come to the June monitoring piece later on, you'll see that we are bidding. The department has, because of the level of savings, because of the increased cost, because of increased demand, you know, no amount of innovation is suddenly going to mean that, you know, we've got enough money to meet the demand, and you can't deliver innovation and transformation overnight, and you can't deliver it without prompt priming in there. So, you know, we are as a department heavily reliant on in-year monitoring, and it's fundamental that you know, we get our budget onto a sustainable footing, and we'll have an opportunity, hopefully, as part of the next CSR budget round, to try and put the budget onto a more sustainable footing.
Well, you know, and you did say that the Minister acknowledged that there was a lot of work going on, good work, and we all say that there is. We owe a lot debt of gratitude to the nurses, the professionals, but I mean, I think someone came to the committee and said they're almost burnt out. and they will continue to be burnt out and leave the service, and it's going the wrong direction as far as I'm concerned. And, you know, unless and until there's sufficient funding there to get us over, rather than relying on the crumbs from the monitoring rounds, we're going to continue from one crisis to another.
Well, I think, as Deborah said, I mean, I don't think you'll find an official in the Department of Health who wouldn't be able to make a case for more money for the provision of health and social care. Unfortunately, we don't set the allocation for the department. We work with the resources that are provided to us. That is very challenging. Deborah's mentioned those challenges in terms of rising prices, growing demand, particularly demand associated with demographic pressures. I would have to say that those are challenges that any healthcare system I look to across the developed world, you see similar problems. I don't think anyone has this sorted out. I don't see any service which says, no, we actually have enough resources to meet those demands. What you do is you work with what you've got, and at the same time you try and position yourselves as best as you can to meet those demands, and that's what transforming your care is about. I don't think we're saying by saying that we're on track to deliver the commitments that we set out in PFG that we don't have pressures or difficulties or strains as a result of the financial settlement that we have. We do. And I mean, we wouldn't pretend that the situation was otherwise.
Right. And finally, Chair, there will be probably more cuts coming down the line. Can you, as officials of the department, give us an assurance that the health will not be seen as an easy target for those cuts, given where we're at the moment?
Well, we can't determine the level of cuts that will be applied to our department. That's not a decision that comes from within the department. What I'll say is that whatever settlement we are given, we will do our best to make sure that that money is used as effectively as possible to meet the health and social care needs of the people of Northern Ireland. I think that it would be wrong to give any false optimism. I mean, the likelihood is that we're facing a very difficult financial time, and that means that there will be increased pressure on services. Now, the very nurses and doctors and social workers and carers you referred to, we will look to them to do their best. We'll try and support them to find new ways of working efficiently and effectively and to innovate, but this is going to be very, very difficult.
Yeah. Okay, thanks,
Thank
Chair.
you, Kieran. And Fergal, next.
Thank you very much, Chair, and thank you for your presentation. I can't measure philosophy, but I try and measure things in time and in finance and in targets and etc. etc. So I too have an issue around this, the Amber Green, which is talks about broadly on track and easily redeemable deviations. So the original Transforming Your Care plan was 3 to 5 years, and we're now in year 4. So on that measurement, on just the time measurement, can we realistically suggest that green and amber is appropriate? Only on the time.
In relation to those aspects of transforming your care that are covered by this programme for government commitment, there are many things that are happening which you would describe as transforming your care activities that are not included in the PFG commitment. In relation to the PFG commitment, I think that to say that we're broadly on track, that it's a green amber rating, well, that's the assessment we came to, and it is scrutinised by OFM DFM independently of us, yes, and they've accepted that rating.
Yeah, but in terms of time, though, given the original time scoping for the exercise 3 to 5, can we say it's easily redeemable? In terms of the original plan as envisaged, just in terms of time.
In terms of time, you know, we are looking at, you know, the plan looked at certain things. It was never specific on, you know, all of the work programmes and workflows that were going to happen below it, and all the multitude of projects that be taken forward. And therefore, you know, 3 to 5 was the estimate at that point in time, without any sort of real dig down into what exactly would happen on the ground. So therefore, you know, this to me, we will be looking at transformation, whether it's more transformation or different transformation under Donaldson and so on. So I think that this is a vision, and therefore we will be continuing along this vision until somebody says, you know what, that's not the right vision, because every time a service need emerges, we will have to think on it, well, do we provide that on the basis of wrap around the patient, or do we provide it, you know, in a community setting?
Yeah, but that's a different answer. Just in terms of time, and in terms of the original concept, we can't say, I would vouch, that this is easily redeemable in terms of the original vision.
I suppose I mean, we will be working to get the shift left aspect increased over the next 2 years, and I would think that we will be able to get that up, you know, another 20 million based on the information and looking at what is being done on the ground out in the trusts. So from that aspect, but this is a journey, and therefore, you know, I don't know when we're going to say we've finished it. So I can't say that it'll be finished in 2 years' time, or it'll be finished in 5 years' time, because to me this is a continuous journey. This is the way we should be. This is business as usual, you know, in terms of what was envisaged by TYC. It's business as usual, and, you know, to say that in 3 years' time or in 5 years' time you'll actually be finished, I don't think you'll ever be finished.
Oh no, I can understand how you might never be finished a project like that, but we do have to operate, because this involves millions of pounds, and we do have to operate to some kind of concrete plans, and it would worry me when things just become vague and philosophical with respect to the language. But so then down to the money, we've 50-50 in terms of the funding. So within the time envelope and the financial envelope, given that we've only shifted 50% of the money in that time, can we say that this is broadly on track and easily redeemable?
In terms of taking the 3 milestones together for where we've got to in 14-15, yes, we can say that. And now we have to continue to work hard and invest to get some more money. In terms of, if we're just looking purely at the 83 million, we have to work to try and shift that. If we're looking at what's going on the ground every day of the week in the hospitals, and trying better to capture all of that, then, you know, we are in a broadly redeemable place because of the amount of work that's going on the ground.
There were 99 targets in total in terms of the TYC plan, so it had actual targets. Whether workflows flowed from that, I question, but how much of the 28.4 million was spent on transferring patients from Holywell?
I don't know the exact amount that was spent on specifically Holywell, but there was a significant amount of money has been dedicated to the resettlement of long-stay patients, both from Muckamore Hospital and Holywell. But that was part of the transforming your care
Would it have been
intention.
Would it have been as high as 25 million?
The shift left is 25 to 28 million in terms of the shift left figure, but
was the Muckamore and Holywell resettlement as high as 25 million?
in terms of
itself spend?
In terms of the costs?
Yes.
I'd have to check for you. Some of the costs were funded from
am I
within
out?
existing resources. Some of the resettlement costs were funded from within existing resources. Some of the resettlement costs have been funded from transfers of funding from DSD. So there's a package of funding measures, and it hasn't been funded, to my knowledge, out of the actual transitional funding.
But how much of that figure, I mean, have you to go and check it
I'll
now?
have to check it for you.
But what
In terms of
kind of
numbers.
percentage are we talking about?
I would have to check it in terms of the details.
And how much money would you have got in from DSD and other sources?
The amount of money that we're expecting, for example, from DSD this year to fund the ongoing service requirement in terms of the community provision, in terms of the housing aspect, is £6 million. That's what we have been seeking from DSD. So I would imagine it would have been similar amount in 14-15, possibly lower the years before.
But we can say that there...
I don't have the exact figure for you, Fergal. We'll get it for you. I think I'll be open with you. A significant proportion of the money has related to the resettlement of long-stay patients.
And I'm not objecting.
Which
that
is
as
a
target.
legitimate
It was a
objective of TYC.
I understand that. But when you subtract that larger sum from the other shift left monies, then we must see that that remaining sum is spread more thinly.
I think it would be fair to say
Given that there were 99 targets, it's reasonable to assume that while the headline figure looks as if it was a lot of money in shift left across the board, in fact it's lesser.
well, some of the 99 targets aren't particularly connected with spending large amounts of money. They're just changing how you do things. In relation to the money, I think it would be fair to say we've been particularly successful at the aspect of TYC which related to moving long-stay patients from institutional settings into their own homes in supported living arrangements. That's where we have been particularly successful.
Okay. At the last meeting, Sean, you promised that you would do a scoping exercise to see if any more money had been shifted left as part of TYC. Was that done? And if so, how much was or wasn't transferred?
We have done some more work with the board in terms of their projections, but I haven't crawled over them all yet because we've only just got them, and until we're happy with them, we wouldn't be accepting them from the board in terms of their proposed increases.
Is there a ballpark?
At the minute, in terms of their suggestion for 15-16, they're suggesting that it could be as much as another 10 million in 15-16, based on this review. Now, that said, the department, we want to crawl over this to make sure we understand exactly where this is coming from and how this is being captured. I do know that they have been looking at some of the work that has been going on in trusts, not funded from the TYC transitional funding, but it's still investment that has been made by the service to support the sort of the wraparound in the community or to hospital avoidance. But I wouldn't want to settle on a figure until we had crawled all over it.
And also, I know you've touched on this earlier in terms of it'll never finish. I worry about that as well, because we do need timeframes, measurables, targets, etc., etc. Julie Thompson said at the last meeting that TYC was now an 8 to 10 year plan. Is that something that's been put in front of OFM, DFM?
No, I don't believe it has. I mean, the OFM, DFM are concerned with the aspects of TYC which are reflected in the specific programme for government target. As to whether something ever finishes or not, what I'm saying is that the philosophy, forgive me for using the word, behind TYC is about shifting the culture of care from one which is based in large acute hospitals to wrapping it around individuals in their own home. Now, that is something that I think you can continually do more on. I think that no matter what progress we make, as you talk to patients and service users, they will continually redefine what they want and they expect of services. So in that sense, I think this work will go on forever. I fully agree with you that you need to have measurable commitments and targets. That's why there were the 99 commitments. That's also why aspects of it were reflected in a PFG commitment, and those things are measured, and that's what we're reporting on now.
And what's the expertise of or even the mechanism by which OFM, DFM decides that these things have been met? Do they rely on your analysis and then agree, or do they conduct their own?
They will issue reasonably robust requests to the Department of Information to back up this, and they will drill down into the information that we're providing them. So they will ask robust, and then as well as that, there's an oversight group, and the permanent secretaries go to the oversight group, and it's discussed and challenged at that as well.
Sorry, who's in that group?
The permanent secretaries certainly attend that. It's a delivery oversight group. I think it's in the briefing, but
So the health permanent secretary?
he will attend that. The head of the civil service
interrogating or is he defending?
He will be defending his position, but the head of the civil service, for example, will challenge them on their programme for government targets as well.
Okay. I've asked 4 Assembly questions detailing the ICP plans across the 17, and I haven't yet to get an answer about exactly what those plans are. Can I get sight of what those plans actually are? And why is it when I ask a question, repeatedly ask it, and ask it again and again, I don't get an answer?
In terms of the plans, there are numerous plans and numerous documents. If it would be helpful, and if our minister's content, if maybe even for 1 or 2 of the ICPs, if one of the researchers maybe wanted to look at them, you know, we could make available. It's not something that you can put into an AQ response because the information would be vast. So if there was,
what I get in response is generalities of where this is all. It's not in philosophical terms, but in general terms, I get answers about where this is all going. But I don't get an answer. Yet I'm asking a specific question and don't get an answer. Mm-hmm. I mean, well, if they can't present the plan, how do we know? They will
have numerous project plans. Numerous project plans for each of the areas that they're looking at, whether it's frail elderly, respiratory diabetes, or and numerous projects underneath that. So there are there are plans in below that, there are spreadsheets in below that, there's all sorts of information in below that, and therefore there's not, as I understand it, a single plan that says ICP one single plan. There's lots of work streams and work plans in below it, in terms of being. So I can't actually send you a single document that says, here's the work plan.
Okay, and can I just take one more, Chair, if I beg your indulgence? Who now is running TYC, given the absence of the previous head?
The Chief Executive of the Board is in running TYC, is in charge of TYC, and Pamela is at the board 1 day a week. She's still.
And this is the same Chief Executive who at a recent conference talked about how TYC was of its time, if you like, referring it to it in the past, that it was relevant to the events and circumstances of 2011.
In terms of TYC, I think it's a way of thinking, it's a vision, it's the way we should be wrapping services around the participation.
Yes,
But
and I know this is hearsay evidence, but I was there to hear it, and I've asked for copies of all the speeches so I can share them with you. Chief Executive referred to TYC in the past.
the department, the minister is committed to TYC.
The Permanent Secretary referred to TYC as being now not so much a plan but transformational.
I think that probably reflects that at a point in time when the document was published, there were 99 specific actions that were deemed to be suitable. Now, if you were to rewrite the document today, you wouldn't write those same 99 actions, you'd write a new set of actions. So I think what the reference by the Permanent Secretary and the Chief Executive of the HSCB probably referred to, and I'm cautious about speaking on their behalf because I haven't discussed this with them, but I would imagine they were saying that the document was published at a point in time, and at that point in time, in order to deliver this transformational vision, there were 99 actions that it was felt were appropriate to deliver. Those have now been done or are in the process of being completed.
We don't say, that's your saying that. I don't accept that they've been done.
I'm talking about the specific 99 commitments that were, I mean, they are being done or have been completed. It depends on each one. They're in different stages of completion.
Can we see a plan then that demonstrates from your perspective
99.
exactly
On the
where they
99?
are in those 99?
We
haven't seen
Yeah, I think
that.
we've previously advised that we are getting a report on the 99 pulled together because we have asked the board to pull that together in terms of the ones they're responsible for. That is due with us shortly, and the Minister then will be making, if he's minded, he will then, make a statement or a briefing in relation to where we are with those. But yes, there'll be a report.
I'm just conscious as well that
the summer.
in his opening remarks as new Minister, I don't think he referred to transforming your care at all. Thank you, Chair.
Okay, thank you, Fergal. Rosie's next.
Gurmagh Carly, and thanks for the presentation. But most of what I was going to ask has been covered. But if I could maybe just say, in a general sense, the rating that is given, the green amber rating, suggests, as you were saying, things are on course and the policy is working out as you would expect. And you put that against the public perception, and Kieran referred to a lot of different things that we're hearing about all the time. So you're asking yourself, if you're getting a report that says we're doing fine, we're delivering, and then the public perception out there, and it seems to be backed up by evidence, that we have a health service which is in crisis, where's the disjoint? How do you work that out? Is there something wrong about what you're doing?
I think that it's the delivery of health and social care. It's the most passionate, emotive and important activity I think government does on behalf of its citizens. And it's something that affects every single one of us, and particularly people who have experience of illness or some kind of vulnerability, who have direct experience of it. Those people who are experiencing those services, whether they're acute hospital services or attending their GP or waiting for a social worker to deliver a care package for them, are seeing a service which is under pressure. There's no doubt about that in all of those areas. And I think that often when people reflect the pressure that they see, they do it understandably in very passionate and emotive terms. I fully understand that. I mean, I think, we all use the health service and social services as well, and we see those pressures. They're definitely there. But that doesn't mean that alongside those pressures, people aren't working very hard to do their best to make the system as fit as possible to respond to those pressures. The things that we're talking about are specific steps that we're taking that are trying to respond to those demands that are on the health service, and we're making progress in relation to those. That's not to say that everything's rosy or that there's no difficulty. This is a system that is coping with very significant demands which are growing exponentially, and the cost of meeting those demands is also growing significantly. So it's understandable that people feel that it's under pressure and they express their frustration. But that doesn't mean that where we've set ourselves some specific targets that we're reporting on today, which we are, that we haven't made measurable progress against them.
Look, me TYC is a vision, and it was set out as a 5-year plan, 5-year vision to deliver this transformation. And after 4 years, would you not have expected to see the juggernaut having turned and things settling down? What was wrong? Was it the actions? Were there actions not the right actions? Or what's the reason for that? You know, the vision doesn't look like it's being delivered.
There has been, I mean, going back to the bit, if you were writing this document today, you'd write a different document.
So you're saying that there were actions that you undertook then that you shouldn't have?
No, it's not that. It's just that, you know, in terms of work has been on a significant change. Significant work has been done on the ground. But in terms of every day, there's new innovations, there's new demands from patients, there's new service needs, and therefore you're on a continuous journey all the time. In terms of the actions that have been taken forward, yes, you know, they're the right actions. They're focused around the patients, about trying to wrap services around the patients, and this move away from everything must be delivered in an acute hospital. In terms of the transition, funding for transitional spend started very modestly in 2012-13, and again, you know, it was modest in 13-14 and 14-15. But even at that, one of the key milestones and one of the key actions was the setting up of the integrated care partnerships, which are fundamental to TYC, and they really, although they were in shadow form, you know, they really only become operational, fully operational in 14-15. So they have been, in terms of their redesign of the interfaces between.
So in the plan then, as it was devised, was it foreseen that it would take like so long to get the plans, you know, the ICPs operational? Was that what you envisaged?
Well, there would always have been a time in terms of getting set up, and the implementation, you know, in terms of that setup, I can't be specific. I don't have any information in front of me today to say, well, the ICPs were meant to be in and there was a delay in getting ICPs. But in terms of the 3 to 5 year plan, it was a very high level aspirational plan. And in terms of that, you know, there were then, after that plan was done, okay, there were 99 high-level proposals set out in that, in terms of work streams, and then the actual meat has to be put onto that in terms of what does it mean on the ground, and therefore, you know, part of the implementation and part of the development work has been then turning those 99 proposals into associated action plans, programmes and so on. So there was always going to be, you know, you were never going to do, you know, land in year one and have a whole lot done in year one, because you had to go through that whole extra planning. The vision was high level. There needs to be that extra planning and then turning that into actions and then turning that into, you know, the models at regional level in terms of services provision across the piece.
It just sounds to me as though there was I mean, we all know that there will be further pressures on health service. That's a given. And so, was that not foreseen? And was it too high level as an aspiration? And are you still following plans that really aren't the right plans? If you're saying it wouldn't be what you'd write now, or have you revised that? You know, are you working to something that's not working really?
I suppose in terms of the plan itself, whenever the plans were done, there were financial pressures, but I don't think they were as severe at that point as we have subsequently seen in the last 2-3 years. In terms of what's happened on the ground, in terms of resources. In terms of where I say we might write things differently, it would be saying, well, actually, you know what, we've done that one and we've done that one, and therefore we want to move that on to a different level now. So you'd be
Can you
actually
give me an
taking on board.
example of we would have done that then, just so that I can understand, you know, what specifically that would mean? Just maybe an example that you have.
I mean, I can't give you any specific example. It would be, you know, in terms of if you sit and you look and you take a stock take, which is what we're doing. We're taking a stock take at the minute of where we are with the 99. And when we take that stock take with the 99, you might think, you know, you go down it and you'll say, well, actually, you know what, we'll do this slightly differently now because we find it hasn't worked.
Can you specify even just one out of the 99 that, you know?
I wouldn't be able to at this stage, but I just know when it comes in that you'll be sitting looking at it and thinking, no, there'll be suggestions for something because they'll have learnt something as they've gone through it, and they'll want to turn it a different direction. They will have learnt from what they've done, and then there will, you know, be opportunities for improvement based on what they've learnt so far.
I just find it really surprising. You can't give me one example, but anyway, thank you.
Did the department fail in relation to putting the meat on the bones?
The department has worked very hard to.
But what you're saying a couple of times there is that we have a very high-level aspirational plan. You talked about if we were writing it today, it'd be different. But we had a high-level plan, and then we needed to drill down. Did you not drill down?
The ICPs, for example, have drilled down because they have.
But the plan.
In terms of the plan had the 99 proposals in it. Those 99 proposals were then turned into their various work streams, and that's the report that we're getting through now. And in terms of that, each work streams would have had multiple strands to it. So, you're sitting with a high-level plan. So there is meat on the bone. There is definitely meat on the bone, spread across all
of the 99 recommendations.
Yes, there's work streams and reports coming through on the 99.
Okay, I think it's on this, Fergal, that you...
No, it's just that, for the last 2 years we've been asking.
Sorry, just 1 second, sorry, Kieran. Fergal was in front of you, and then I'll bring you in.
It's not as if we haven't been focusing in on these very questions for 2 years now. We said, where were the targets? Where was the measurement? Where was the money? And it never appeared. We have seen nothing of it. And as I say, I continue to see nothing about ICP, which is the further bit that you're talking about. We don't get it. So, and this is
I
the
think there was a paper
scrutinising
sent to
committee.
the committee with an update last year at around this time on the 99. My knowledge.
But sorry, Fergal, for jumping in on top of you. Part of this gap in relation to transforming your care was the lack of that strategic outcome framework that told us if we shift left, it will mean A, B and C. It will have X, Y and Z outcome, which is about a better health outcome for all of our citizens. That's what was missing. And that's what I seem to be hearing from you today as well.
The original, the high-level document has in it the aspirational piece about wrapping around the patient and, the community focus and better outcomes and all of those aspirational pieces. Then there's the 99, and then below the 99, there are various work streams on the go, multiple work streams on the go under the 99. So those are all there, and some of those will be right down then, when you take those work streams, some of those will be out then into the ICP work streams. So there's multiple work streams. It's a very, very complex level of work streams, which is why, in terms of us now working with the board, they're having to go out to all of the trusts to get information on where they are with their aspects of the work stream. So it's not just the department and the board, it's spread right across the health service in terms of this, and that's why then in terms of getting the report, we have that. So there is meat on the bone, there is a plan in terms of all of those actions.
Okay, and I'm going to bring Kieran in on this, sorry.
I hear what you're saying. Look, when you see headlines like that, lives being put at risk, and there were 700 operations cancelled from January to March. Surely the Transforming Your Care story, we're only 5 years into it, and it's not working, and you see headlines like that there, where lives are being put at risk. Something drastic has got to be done in terms of where you go from here and carrying on with this philosophy of transforming your care.
In terms of those, I think the story you're referring to is specifically related to the unscheduled care pressures that we've faced in the first 3 months of the year.
700 operations cancelled.
There's an important point in this, and I know there's 2 more speakers, but from your perspective, I'm listening to you about financial constraints. I think we can all accept that. There's also a challenge about where current spend goes in health, in my view. But what in the system needs to change to allow you to meet your programme for government targets?
In terms of the programme for government target that we're looking at for 14-15, which was the very, there's three milestones. So the programme for government target in the amber green is for the 3 years, which is why it's amber green, and because we're 50% of the way there in relation to the 83 million. In terms of moving forward, we will need increased investment in service development, and you cannot do transformation without clinical engagement. To have clinical engagement, you have to backfill with locums. So a lot of this comes back to resources.
Right. Look, leave park resources. What in the system? We've had a number of reports now, namely the latest one is the Donaldson report. So I'm just asking a direct question. The Jews have to meet programme for government targets. There are various ones in front of us today. What in the delivery of health needs to shift, change, reform, be removed or altered to allow you to do that?
In terms, I think the Minister is clearly on record that we need transformation. He's clearly on the record that transformation includes reconfiguration of services. And being honest, from my point of view, that is about reconfiguration of services and a move away from services in terms of, you know, Donaldson mentioned the acute hospitals and so on, in terms of the provision of acute hospitals. So I suppose we have as a system to be bold and look at and be prepared to accept, based on evidence, the reconfiguration of services.
I think also, Chair, it's worth pointing out that, I mean, to date, we've spent all our time focusing on one of our 6 commitments for programme for government, which we're rating as being green amber, partially completed. There's been progress against all 6 of our programme for government commitments. So you're saying, what would we have to do to deliver on our programme for government commitments? We actually have delivered on our programme for government commitments.
Right, well, okay, I'm asking what the system needs to do, but okay, because there's another few people have indicated. Alex first.
Thank you, Chair. Number 10, you mentioned about activities planned for transforming your care for 2014-15, and that you aren't able to do all those because of funding. Can you tell me what ones you aren't able to take forward for that period that you didn't have funding for?
I don't have a specific list with me, but we had planned to take forward projects in the earlier part of the year. We had got requests in from the ICPs to take forward various projects. We would have needed, for example, to recruit staff to those, but we couldn't recruit staff ahead of getting the funding, which meant that if we hadn't recruited staff early enough in the year, we then couldn't have spent the money on delivery. So we were stuck in some cases because of, you know, the plan that we would have had in June would not have been the same as the plan that we ended up when we got the money in October.
Chair, would it be in order for us to see the list of what wasn't taken forward? That would be okay to us.
No issue. And
Can
you
you supply that for us?
I'll ask the board for that, yes.
And in terms of transforming your care, how much have you actually spent on it so far?
In some 26 million.
How much do you need?
The original estimate was some 70 to 75 million.
Okay, thank you.
okay, thank you. And Michael?
Yeah, just very briefly, because what you're painting is really a repeat of what we've been hearing at this committee week after week after week, and the sort of pressure and effectively, Rosie called it the health service crisis, and I don't think anybody would disagree with that around this table listening to what we're hearing. What interests me is transforming your care, a process whereby you invest and support services in primary and community, and that allows you then to start reducing or reconfiguring in secondary care. And it's logical, shift left, now it's called transforming your care. And it went off with a great fanfare in 2011. What concerns me is who actually is implementing this, who's in charge. Your job's policy. You say, here's the policy, this is what we want. We want services built up in primary and in community, and that'll allow us to reduce demand in secondary. All sensible, and you have a number of actions and all the rest of it. But it's not your job to actually do the business of overseeing it and making sure that works. And you hear about work streams, I think, work stream after work stream. Whose job is it? Is that not the board's job, responsibility for implementing transforming your care?
The board's responsible for commissioning services which are in line with the vision of transforming your care. Yeah.
They're responsible. They buy the services from the trusts. They have commissioning groups to inform them on what services they need. They have a public health agency that has not exactly a veto, but certainly a major say in how those services, the plan for those services are bought. What I don't understand is if you have integrated care package partnerships and you're saying those are absolutely vital to the process, and it took 4 years to set those up. Who set those up and who took 4 years over setting them up? Because that is a vital part of all of this. You've got a job to do. You write the policy. Here's that. This is what we want. But you've got a board, and it's a very expensive board, God. Far more people down there than ever was envisaged or planned. And I wonder why the board is not delivering. And if the board's not delivering, what are you doing about it?
In terms, you're quite right, in terms of the actions on the ground, then those actions are twofold. There's the transitional work, which is taken forward in terms of design and new innovation, and that's where some of the seed funding and the transitional funding aspects are applied. And the other aspect is then commissioning services, which reflect the TYC, and those are responsibilities of the board. In terms of the board, there are accountability mechanisms in place, including reporting to the Permanent Secretary from the Chief Executive in relation to that. Obviously, there are constraints on the extent to which the board can do some of this out and how fast it can go, and those are mitigating factors. Whether they would be all of the factors, I'm not commenting on that at this stage. But in terms of holding it to account, ultimately the Minister will hold the Chief Executive.
But is that happening? You say you have a plan, but the plan doesn't appear to be, it appears to go on adrift. You say there are constraints that the board's working under. What are those constraints? What are the obstacles and how do you get over them? What are the problems and how do you deal with them? You have a very elaborate board there. It's got very complex in the last 4 years, far more complex, far more expensive, far more people than ever was envisaged. You actually did. You should have people coming out of their ears to do this now. I asked the question when I think it was Jim Wales was the Minister, and the original board was to be less than 400, never to go over 400, and only in extreme circumstances. When I left, it was 358. It's now at, what is it, 525? And I was told, well, the reason for that is we took out large numbers of people who were brought in short-term contracts to do transforming your care. I mean, what is going on down there? When we have a chief executive of the board who is very well paid, probably getting more than you're getting, to do all this, and yet there seems to be no delivery. You hear members talking, and we all feel exactly the same. You hear the public talking. We look at your waiting times, whether it's inpatient, whether it's outpatient, diagnostics, cancer waiting times, everything slipping, A&Es, all the rest of it. And this is the board, this is the responsible management tool that you have. And this management tool doesn't appear to be delivering or working. And I'm just wondering why, and what are you doing about that? Because if that's your problem, deal with that in order to get the rest going.
Key issue, and sorry for repeating it, but a key issue comes down to resources. You've mentioned the waiting lists initiatives. Again, that comes down to resources. Service developments, you'll hear later on the extent to which we can't afford service developments in 15-16. And, you know, whilst the board, for example, like all the other arm's length bodies, has been set savings targets and has to deliver set savings this year, that savings targets have been applied, you know, to the various organisations. But, you know, in terms of delivering significant change and significant shift, you can't take the money out of one area until you have set the service up in another area. So therefore, it will always come back to an element of resources. And whilst we can look at ways to try and be more efficient and effective within existing resources, you know, to take a service away from providing it this way, you have to set it up so that it's ready to run another way, and that inevitably will take time and resources. So resources, to me, you know, in terms of when you mentioned the waiting lists and so on, that's a key aspect to this.
Okay, that sounds like something I've heard before. Now tell me this, what sort of resources are you talking about?
I think when we're coming to June monitoring, the bids on the table in excess.
It's not just about June monitoring, what you can squeeze here, there and everywhere, which is no way to run finances in a health service. What are you actually talking about? You're bound to know what this actually costs. You're going to have a ballpark figure. I know you hear 76 million, you have a 26 in, but that was never going to do it. Building up and investing in primary and in community to allow you to press down on demand and secondary. because you're never going to save money in secondary. What you might do is you might be able to
You might
plateau
be
the
able
money a bit.
Plateau and deal
But that's
with
going to need
demand.
very significant investment at the other end, at community and at primary care. I mean, we've been through this so often, but there was always a figure and a notion. So what figure are you working at? Because then you've got a timeline, you've got a plan. Your timeline's gone, as far as I can see. You have a plan. The plan is getting confused. Trying to implement this plan is creating tensions all over the system. And the resource, you're saying, so what is the resource you need to keep all this? You've got to keep secondary show on the road, you've got to keep primary and community, and then you've got to build to allow this shift left.
In terms, I can't give you a figure today on terms of that. I don't know
Here,
whether
listen,
Julie can give you
You
a
guys
figure.
will know exactly,
today.
roughly, not exactly, but you know roughly what you need. This has been talked over and talked over and talked over through work stream after endless work stream for several years.
Well, I can't. I can give you a figure today, it's possibly before my time. But in terms of, maybe Julie can give you a high-level ballpark figure in terms of, but you're talking about a figure to fix the whole of the health service, to deliver elective care permanently on time, to make sure that there's sufficient in-house capacity, and
See
that you,
patients timely.
that you weigh down, you bear down on the independent sector and so on. And we're working with the board to have a roadmap for elective care. We will also, the picture that we have today may well change in terms of where we're going in the future, depending on the Minister's and the response to outcome and the Minister's view on the Donaldson report, and that will have financial consequences. So I can't give you,
Costs a lot of money.
I can't give you a figure.
Who can give me a figure?
I think there's, whenever we see where Donaldson takes us, whenever we see where the Commission
Hold on.
review takes us,
It's where you are now at this point in time. Donaldson's not here yet. But Donaldson's a proposal, more work streams, all the rest of it. It's the current moment, this point in time. Who can give us an answer?
I would be guessing today, unless, I don't know.
Well, I think we'll get some context in the next hearing scheduled straight after this, because obviously what we're bidding for in June monitoring reflects where we see pressures and where we see
year.
gaps in this year.
It's emergency money.
Well,
That's
I
strategic
think it's money that also can allow you to develop new services. I mean, you can use it strategically.
Right.
Okay, I mean, it's not very heartening in relation to the implementation of the aspiration and the vision of TYC, if we don't even know how much it's going to cost to do that. So I'm going to move it under the second part of the conversation, which is in around June monitor. I think Julie is joining us at this point.
Definitely is.
No, it's okay. It's actually true. Okay, folks, Julie, you're welcome to the meeting. Just going to ask him, I'm assuming it's yourself, Julie, to make the opening comments, and we will open it up. Obviously, there has been a link in relation to the programme for government commitments that's just come through. So I'm asking members to bear that in mind as well, and try to be as specific as possible and in around June monitoring itself. So Julie, I'll hand over to you.
Okay, thank you for the opportunity to provide evidence to the committee today on the Department's proposed approach to current and capital expenditure investment in the June monitoring round. And the committee had also asked for some information on 14-15 and 15-16 savings. In terms of current expenditure bids, we have considered a range of factors, the most significant of which continues to be the financial context for 15-16. At this stage, our latest assessment is that there is an unresolved gap of some 30 to 40 million for 15-16. And as previously outlined to the committee, this assumes that there are no new service developments able to be funded within 15-16. It is, however, acknowledged that the availability of funding in this monitoring round may be limited in light of the wider constrained funding environment and the challenges facing the Executive. Notwithstanding this, we are proposing that 4 revenue bids should be submitted. 23 million is proposed to be allocated for a range of priority pressures across existing service areas, such as learning disability resettlement, public health initiatives, unscheduled care, patient flow, and the revenue consequences of a number of capital schemes that are due to open in 15-16. A further 45 million would be used to deliver additional elective care capacity across a range of specialties. And that's anticipated that this level of funding would allow a further 58,000 assessments and 13,000 treatments by the end of March 2016. A bid for 5 million for a range of TYC reforms, and 16 million to be directed at a number of prioritised service developments such as specialist services, mental health, learning disability and children's services. Members will note that the bids have also been prioritised in line with DFP requirements. As previously advised to the committee, additional funding will be required by the Department through monitoring rounds in order to avoid unacceptable service consequences. Turning to capital expenditure, any bids must be for projects that can be fully spent in 15-16 and must not carry a tail into 16-17. We're therefore proposing to bid for some 45 million for a range of capital projects, including maintaining essential services, medical equipment, estates works, fleet, ICT and Invest to Save. Turning to savings in 14-15, the Department committed to delivering some 170 million of savings, and this target has been achieved, and we're currently working through and reviewing the progress within each area as part of our annual reporting process to DFP. For 15-16, savings opportunities and cost reductions of some 157 million have been identified at this stage. This includes opportunities of 105 million at the trusts, 25 million in relation to prescribing and family health services, and 30 million in relation to departmental and ALB savings opportunities. Trust boards have approved the savings plans a few weeks ago, and trusts are moving forward to implement their plans, and this will include the consideration of consultation processes as appropriate. We would strongly commend the Department's bids are considered favourably by the committee. I'm happy to take any questions from members on any of the issues raised.
Okay, thank you, Julie. I suppose it's hard really for me to understand, given the fact that the backdrop for monitoring in terms of the Department's agreement is for major and unforeseeable circumstances.
Yes, and I think that's a subject we've had a discussion with the committee about. That is exactly the scenario we're in, but equally, because of the scale of the pressures that are within the health service, DFP has not precluded us in the past, and has certainly not indicated that a bid or bids in this monitoring round would be unacceptable to them. That will then be a matter, obviously, for the executive to consider, alongside all the other pressures put forward by other departments.
But we could stand over, or you could stand over at this point, that those bids are major and unforeseeable.
They are there in the context of the entire financial position being considerably, I guess, worse than maybe it might have otherwise have been, and therefore we need to put the bids in to reflect that.
But you know, and I'll use an example: waiting lists. We can't say that's unforeseeable.
What we can say is we have considerable numbers of people and patients waiting on waiting lists, and that money available, if it would become available to the department, would make a difference to those individuals, and hence the bids are going into the system, and obviously the executive can consider those against other departments' priorities.
Okay, and the total bid is 89 million?
That's right.
In terms of, I think, Julie, you'd alluded to, they've been prioritised as per DFP request. Transforming your care is number 3. Again, you know, does that mean that it's the 3rd highest priority?
What it means is we obviously have to ensure that the existing service base is fully funded and can work forward as out of the back of the monitoring rounds, and that's the bids that have been put at the top of the pile. So the ones that are affected with existing service pressures, it reflects the fact that we're £30 to £40 million with a funding gap at this stage. Now that has to be resolved first before we put additional money into TYC. There is money absolutely been invested in TYC, and I'm not sure whether you've already had that bit of the conversation. So the £5 million that we're bidding for would go on top of the funding that's already assumed for TYC going into 15-16. So it's not that nothing would be happening there. This is going on top. The other bids are taking priority because they are reflecting against that expenditure gap that we've currently got, and we have to bring that and sort that first before we can look at the wide range of service priorities that we would wish to invest in.
I just don't get that. I mean, again, the policy context, the vision, the aspiration was the widened framework of TYC in order to address those service issues and gaps, and yet it's priority 3. I don't get that logic. It suggests to me that it's down the pecking order, that it has reduced in significance.
We can't put money into new services until we have resolved the actual funding gap that exists within our current base. And that's where the priority has been given to, that the funding needed to sort out the baseline issue, if you like, and the gap that currently exists. When we've sorted that out, you can then move to looking at other service developments, such as putting further money into TYC or into other service developments. The elective care has been put in as a priority, given the number of people that are currently sitting on waiting lists and the need to make progress for those people who are currently waiting for their treatments.
You told us as well previously that there was 15 million to be spent, planned to be spent on TYC. So now this 5 million that you're bidding for is in addition to that. Is that what you're saying? Okay. Okay. I'm going to come back because there's a number of things just jump out at me. Well, I'll point to one first before I move on to the other members. The question you've indicated the shift almost in relation to domiciliary and residential care, and you talked about a further move of services from statutory sector to independent.
I guess I think what you're referring to is within the trust savings plans, that they're looking at a range of social care opportunities. I'm not sure whether Sean wanted to comment on any more detail on this, but they're looking at how they can potentially consider their domiciliary care provision and how that can best be provided. And each trust is considering that, and that may lead to use. I mean, you know that the independent sector is very, very active in the domiciliary care arena, and it may mean that there's more use made of that independent sector provision. It's different within different trusts across Northern Ireland as well, so it's reflecting that as well. And it's the trust, we will be putting additional money into domiciliary care, but equally the money that is there we want to have as effective as possible.
But has there been a cost analysis done of services within the system as opposed to independent? Has the department done that piece of work, or are likely to do that?
Individual trusts do that piece of work when they're delivering their savings plans. Particularly, I think it's the Northern Trust has put a particular emphasis on shifting commissioning or provision of domiciliary care from in-house provision to the independent and third sector, and they are specifying that they can deliver savings by doing so. So they are the people who have done the analysis to say, if we move from in-house provision to moving to independent and third sector provision for that particular service, we can deliver a saving. I don't have the exact saving figure in front of me, but it certainly features, I know, I think most predominantly in the Northern Trust savings plans.
Okay, you see, in relation to how the general issue here, and then I hold this view around where money currently goes, and being able to stand over that process and say, hand on heart, money is going in the right direction. And the DFP proposal last year, that there will be additional oversight on the department. Where's that at now?
In terms of that, they are looking at where the money absolutely goes in terms of, and that will be reflected in where our database, if you like, reports. We report into DFP on an ongoing basis, and it will be picked up by DFP reviewing the figure work that we supply to the database and confirming that that expenditure within trusts is increasing as was intended, and that's where they will go with that. The other element of it was the an OECD review, and part of the work around that was to consider, I guess, our provision and how that sits. I'm not sure whether Deborah wants to comment more on that particular aspect. So there was two aspects of it. One will be checked by looking at how the figure work presents itself by DFP, and then the other
and what are the findings?
OECD. Given we're so early in the financial year, there's no findings yet on that one.
There's no indication of how that additional oversight is impacting. Or
no, because it has to report through, if you like.
Yeah, but you have done an initial report for it.
We have looked up, and obviously we know that there's considerable pressures in trusts which are actually way over the 200 million that we currently were allocated, less the savings that were to be achieved, and we know that there's over 300 million of cost, if you like, needing to be put in to address the pressures that are out there. So we're happy enough in that we know that the pressures are there, and we know that savings, far more than the 49 million that was in the budget document. We're actually assuming savings of up to 160 million will come through. Now that all takes time to work its way through in terms of spend levels and forecasts and whatever, and DFP will come back to that when we've got sufficiently through the year, but we're literally in set-up mode with that in terms of it being so early in the financial year.
Okay.
Kieran was next.
Thanks, Chair. Thanks, Julie, for your presentation. First of all, can I get it clear? Last year's deficit, you're in the same position where you put in money. I forget what the figure was for September monitoring round. I think it was maybe October, and you didn't get all you want. I don't know what the figure is, but can you tell the committee? You mentioned 30 to 40 million gap, 15 to 16. Is that where we're sitting at the moment? There's a 30 to 40 million gap before we start off.
Yes, in 15-16 with a £40 million gap, and that sets aside, if you like, anything to do with new service development. So on our existing service provision, having looked across the piece and identified savings and plans, and looked across the piece and identified where all the cost pressures are, we're £30 to £40 million short. And that was the case, if you recall, when I talked to the committee, and I think whenever it came in March. The figure work hasn't moved an awful lot since then.
So if you had 40 million, the department would be up to date and could provide all the stuff that we're talking about, the waiting lists and the cancelled ops and all the rest of it.
The 40 million would bring us into a balanced financial position on existing services.
Right.
What it wouldn't do is address service developments. So those need to be looked at as well. So that's where a lot of the gym monitoring bids then are around bidding for money, for example, to invest further into children's services or mental health or nice drugs or whatever. Okay.
You've got your 40 million. And hopefully you do get your 89 million, will that bring us up to eradicating this sort of stuff here and the lives being put at risk? Because that's what we want to hear. We want to hear that if you can get that, and we'll support you wholeheartedly to get £89 million and bring us right up to where we want to be for our constituents.
Yeah. I guess what it is us looking across the piece and prioritising the service developments and working through to say, well, those are investments that we could make in the currency of 15-16, so you have to be able to spend the money as well, obviously, and that would allow us to move forward on a range of initiatives, including the 45 million in elective care, which would make a considerable difference to those patients, absolutely. Yes.
The other thing that did concern me, and the Chair mentioned it, was in the savings, where you say the domiciliary care. This one scares me because from what I'm hearing is we know that we're going to need more funding for domiciliary care to keep people in their own homes as long as possible. But you're looking for further savings there. So that means that there's going to be some people go wanting.
There's two things going on in domiciliary care. One is that, yes, additional funding will be provided because you're right, people are getting older and require more packages. So there is money going in for that to enable that to happen. What is also, though, happening at the same time is we need to ensure that that provision is being done as efficiently and effectively as possible, and that's where the savings side comes in. So both are happening at the same time. Money will go in for new packages, and those, I'm sure Sean can talk more about the intensive level of some of those packages going in to keep people in their own homes. And then we also then have to ensure we are making the savings out of that as well, that it's done as effectively as possible. And the two can go hand in hand with each other in terms of making sure that we're dealing with that need.
It's the point that was made earlier, where you have a situation where a trust believes they can get more value for money by changing the provider of their domiciliary care and make savings in doing so. We're identifying a savings that can be achieved from that. But simultaneously, we recognise that the number of people, particularly the level of complexity of need for domiciliary care, is rising. So we're simultaneously investing in increasing investment in that to meet that demand.
As long as the people that require domiciliary care can get it when they need it, that's the thing. You're talking about savings. That sometimes means cuts, and that's what would worry me. That some people will not get the care that they're entitled to. But going on, I mean, the 23 million existing service pressures will deal with this, plus the 45 million, and then you've got 16 million for prioritised service development, and the 5 million for transforming your care. Well, again, as the Chair says, 5 million, well, it doesn't need very much to bring us to where we want to be in transforming your care. Could I ask, finally, Chair, given the current uncertainty around the executive and departmental budgets, and in particular the very wide range of financial scenarios, what financial planning is currently underway in the department?
In respect of that, we are looking at all the funds, if you like, that are currently uncommitted. And therefore, in theory, could be stopped. Now, those are wide-ranging. For example, there is some money within the elective care space that is intended to be spent. This money that we're bidding for would go on top of that. So we know that all the domiciliary care packages are obviously not all invested yet. In the ones that will come in through the later part of the year, there would be monies, if you like, that would be intended to be invested in ICT. Anything, if you like, that is planned to come in later in the year, we're keeping a record of that to understand what that looks like. Now, it's not huge amounts of money. The main, I guess, way that this would translate is if money doesn't become available, then elective care waiting lists would go out further, if you like, and that would obviously be a significant concern to us. So we're keeping, in terms of financial planning, we're looking to see what are our options around monies that we had labelled against certain things and whether those could be stopped. But there isn't a huge volume of that. Obviously, trusts are spending money on an ongoing basis. We're a demand-led service, so the people as they turn up have to be treated, and that will continue to be the case. So there's no planning around not treating people or not keeping people safe. That's very much has to be part of how we move forward, and has to be the primacy as we move forward. So what we're more looking at is about things where potentially there's an element of choice. But in the area of even elective care, you would obviously want people to continue to be treated and to keep those waiting lists as low as we can keep them. So it's challenging, but we've certainly, and I know within the department, we have considerable stops and checks in place about when money can be spent and when it can't be spent. Out of the back of June monitoring, then we would need to understand where we are at and make sure we have a viable plan to live within the resources that we would have available. Yeah.
Finally, I hope you get this 89 million because we want to see the whole department, the whole health facility being brought up. We want to cancel all these waiting lists and delayed and all the rest of it. But what happens if you don't get it? Because I've seen, as I say, last year where you had applied for whatever it was, but you didn't get what you want. If you don't get that 80 million, where is our constituents going to be in relation to health provision?
Well, that will be obviously a matter for the Minister to reflect on out the back of June monitoring. As I say, what we have at the moment is when you can't invest money, I guess, that you don't have. And therefore, in terms of service developments, those service developments wouldn't be able to go ahead. In terms of dealing with the gap and the £40 million gap, what could happen is those uncommitted funds that I talked about would then have to remain effectively uncommitted. But it would be up to him to decide what and where and how and exactly how that would actually work its way through. So it certainly would have an impact, there's absolutely no doubt, on waiting times again and take those back further. It could mean that existing capital schemes wouldn't be able to open on time. It's those types of choices that the Minister would have to consider and to establish how we maintain patient safety and client safety, meet the demands that are out there, and yet live within the resources that we've currently got.
So if the Minister knows exactly what's required, what you're telling us, and he is able to get that finance into the department, we should be in a much better position. We should be in the position where we all want to be.
Certainly.
Ask us from when would this funding come
The 89 million June monitoring is due to be discussed or agreed at the executive towards the latter end of June. So yes, it would mean a big difference to us in terms of if we got the 89 million, it would allow us to move forward and actually put those investments on the ground that we're bidding for.
And you would not be coming back in 6 months' time looking for another whack out of the September monitoring round. You should be moving an even keel right throughout.
Well, I guess that's about understanding where we are at that point. So I couldn't say that we wouldn't ever come back. It would depend what we get now and then how service demands move in the interim time. So that would be a matter to reflect on. But certainly 89 million would help considerably in our outlook for 15-16.
Okay,
But if
thanks.
you don't get 89 million, what's your top priority for those four bids?
The top priority will be to balance the books and maintain patient safety. So the ones that are at the top of which are labelled
So
as
is that
existing
within
service
existing
pressures.
service pressures?
Yes, those are the ones effectively that are on the ground, if you like, and therefore need to be properly financed
So that
to enable
becomes
those to happen.
that becomes the top priority.
Absolutely, yes.
So transforming your care obviously is not.
In that we have to deal with the existing service provision that we've got and ensure that that is fully funded. If we don't do that, then something else has to give. We have to sort that out first before we can put new money on the ground for new things.
Okay,
Can I maybe
Fergal,
just
head
add,
on to
Chair?
Sorry,
There is a single bid in for 5 million for TYC, which is really focused on the transitional work streams and the innovative pieces. But as Sean and Julie alluded to earlier, you know, there's increased domiciliary care packages being provided, so that is being funded. So that is part of TYC in terms of the bigger picture. In terms of the £23 million bid, 6 million of that is to assist with sort of unscheduled care and patient flow, and part of that is to increase the capacity in community nursing, is to have more rapid response clinics in community hospitals. So, you know, in terms of, there's one £5 million bid which is for TYC, which is sort of the transitional pump priming stuff, but in terms of the day and daily stuff, that is part of the existing services as well. So I wouldn't want you to think that the only thing that we're doing on TYC is the £5 million that is under the TYC transitional funding banner.
I'll accept
Because-
that, but we also asked earlier about the scoping exercise for services that were actually being shifted left. And I'll make that point again. But anyway, Fergal was looking to
Can
come
I
on
just
this.
further interrogate the £89 million? Because do you recall the figure that you put a bid in for in January and last October?
Last October we bid for 130 million. Last January, I don't have that, like, if you give me a minute I can really get it.
It went from 160 to 140. I think.
160 went to, I think, 130, and then I'll be able to get just keep talking.
Oh yes, so I'm just wondering then, in realistic terms, if you scale these things down percentage-wise, what's the realistic amount
Yeah,
of
we
money?
bid, sorry, just to answer your question, we bid for them for 23 million
That's
in
right.
January.
Yes, I knew those are 23. I think you got 3. Did you?
Got nothing.
Got nothing. Yeah. So anyway, you can see where I'm going here. You have a bid in for 90. What's the likelihood that you'll get 90?
90, given the challenges across the executive, will obviously be a challenge. Nonetheless, all we can do is put forward the bids and the priorities as Minister wants them to go forward, and then the executive will decide. We don't know what will happen. You're absolutely right. We have not got in recent times the full bids that we have asked for, and that will mean that then decisions have to be taken around priorities. And as I've already said, addressing the existing service priorities will have to be the first call on that before we can move forward into new spending going forward.
How will you deal, for example, with the backlog that's already there in terms of elective care and the fact that you're not funding externally on that?
At the moment, it's not that we're not doing anything in elective care. It's a bit like what Deborah was talking about in TYC. We would be putting at around 60 million into elective care. The bid that we're asking for in terms of the further 45 would bring us up to where we believe we need to be moving forward. It also reflects what is spendable in the currency of the year. So it's not... it has to reflect a kick-off position from July as opposed to a run rate that you're going through from April.
Yes, but what are the implications? I'm asking, what are the specific implications if you don't get
The
money that you're
implication
after.
is on that one is that we won't, the 58,000 assessments and the 13,000 treatments won't be able to happen, and the impact therefore for those patients that they will have to wait longer. Now, in line obviously with clinical priority and chronological order as that falls with the clinical priority. So that's the impact for those patients, which will obviously be mean that the waiting times will be longer.
Can I touch on the savings as well? And do you recognise the story in the Irish News today as being accurate?
The Irish News story is around more about the service developments that aren't able to happen, as opposed to the savings cuts or reductions in that sense. I know the phrase of cuts is used, but it's more about the fact that investment won't be able to happen in particular areas, whether that be waiting times or whether it be the areas that we're bidding for around specialist services, nice drugs, children's or whatever. So I certainly recognise the concept of the fact that unless we get the money through these bids, as Mr McCarthy has already talked about, then we will not be able to do those things. So the story, as I understand it, is not about savings plans, but more about lack of service development funding.
There's the headlines there. That's 2-page.
Oh, I understand. Yes,
It's unbelievable, as far as I say it.
Journalistic licence.
In terms, you've mentioned NICE a couple of times now, and up to this point, the issue around NICE has been non-approved drugs and dealing with the IFR process. Are you now saying that NICE approved drugs and processes that are available and could be available here will not be available?
That's where we currently sit, and where we have been, if you like, from previous conversations with the committee. What we can do is continue to give NICE treatments, existing NICE, to new patients. But for newly approved NICE that are coming on stream in 15-16, that's the element, if you like, that the bid in June monitoring would resolve for us looking ahead.
And would you understand that to present a difficulty for professionals?
It'll present a difficulty for both professionals and for patients, obviously, in terms of what...
Where a professional knows that a treatment is available now under national government, could make a difference to their life, and that professional will not be allowed to administer that drug, though it would be available elsewhere in the UK.
And you could make that statement about the fact that they know that people on waiting lists for operations, clinicians know they could treat them, but they aren't able to do it. So it's the same concept of that. It's the same as criteria being applied in domiciliary care. It is when you've got a demand-led system, as we have, of course that clinician and those clinicians will want to give the best possible treatment, and we would want that too, and the Minister would want that as well. But we have to live within the resources that we've got, and currently the money does not exist for that. Now it's within the bidding that we are putting forward, and it would be obviously a significant concern if we can't allow those NICE drugs effectively to move forward.
And can you say that you're dealing comprehensively with wastage in the health service?
What I can say is we're taking considerable look, as you know, on an ongoing basis about efficiencies. We have challenging efficiency targets on an ongoing basis right across the system, not only the trusts but also our arm's length bodies. And we are looking to ensure that those savings come out and have done so across recent years. Does that mean to say that we've captured absolutely every ounce and every element of wastage? No, I can't advise of that. But what I do know is we continue to look at, and that's right from administration costs and management costs, procurement, estates, right the way through to lengths of stay, day case rates, so it goes from very back office type work right the way through to how do we do the front line more effectively. So we're looking right across the piece there, and we will continue to do so, and I'm sure there will be more efficiencies that will come out in 16-17 and 17-18.
Assume that you're saying in your earlier comments that in fact the Irish News story is accurate, and so it's referring to the inability, if you like, going forward to provide safe, high quality and accessible care. How then, given what Sean was saying earlier on in terms of reaching out for even cheaper care, can we be assured that that process, particularly in terms of domiciliary care, will provide safe, quality and accessible care.
In terms of the safety point, I think it'd be, I need to point out obviously that the safety of both patients and clients is the priority of the system, and all the Trust Chief Executives are fully aware of that, and that needs to be and will remain the priority moving ahead. And, I'm not sure in terms of picking up the specific of the domiciliary care issue. So, you know, yes, we absolutely need to maintain that safety as a priority.
I mean, services, we assure ourselves of safety of services through a number of different mechanisms. I mean, services provided directly by trusts are provided within a governance framework that the trust operates to make sure that services are operated safely. There are mechanisms to identify where there are errors or mistakes and systems in place to learn from those. There's a responsibility on both the board and the trust when they commission services to be assured that the services they commission are of an acceptable and appropriate standard. And then other services specifically are regulated by the Regulation Quality and Improvement Authority, and that involves standards being published and those organisations and the services being inspected against those standards to assure that they are of an acceptable, safe standard. All of those mechanisms do not eliminate the possibility of error in services, but that's true of all activity. I mean,
but do you accept that the downward spiral on cost is producing huge pressure on even or all providers, but particularly some of the independent third sector providers to deliver proper care?
I think that the pressure on cost puts pressure on people who are trying to provide services safely within that cost envelope.
Yeah, but that's a structural issue going forward. That's your decision to commission that at that cost. That's before anything happens. You haven't commissioned yet that's a threat to quality and safety.
Our decision is to try and ensure that we get the very best value for money for the limited resources we have available to us to meet the health and social care needs of the population of Northern Ireland within the boundaries of safe practice.
But if just to balance up the two sides,
if someone comes to us and says we can do this for that price, and we say no, you can't, that's clearly not safe. We don't buy it.
Okay. Well. You will be aware, and you will have heard of how independent providers and others feel that this is so constraining that it does question their ability to provide a safe service.
Well, I mean, there are times when inevitably people who are running businesses will be facing a challenge in terms of how they manage to provide a service which is to the standards and make the profit they need to make. What I would say is that there is a marketplace and people are in the market. If they weren't able to provide the services safely, and there are methods to assure the safety, if they weren't able to provide those services safely, they wouldn't still be in business. They weren't able to provide them safely at the prices that are being charged.
Okay. There. Thanks, Chair.
Thank you, Fergal. Alex, next.
Thanks, Chair. I know everything that you're looking for in the Dream monitoring around is vital, but would you agree with me that the elective care and diagnosis is particularly important, that you get that money?
I think it's all. I think members will have sure support and would recognise the importance of all the bids that we have on the table here. There's no doubt that yes, absolutely, elective care is important to us, but equally so are the other bids that are on the table. The elective care will make a difference to those individuals and will mean that they don't have to wait as long. You know, the other bids, I think, are compelling bids as well. And then the executive obviously has to put these bids alongside all the other bids and then figure out from there what can be funded. But no, we believe we've put forward some very compelling bids and that those services are absolutely needed.
Yeah. You mentioned in your briefing there about uncommitted expenditure identified, if you had to go down that route. How much money have you identified through those?
In terms of that, I guess the monies that are held back, for want of a better word, are in the order of 30 to 40 million, something of that order. There's further money than elective care that could add to that as well. So we have it's in kind of double numbers as opposed to going into hundreds of millions. So it's in that sort of order. Now, if you then say, well, actually, no, you have to stop and do something more radical, then obviously you've got agency spend, you've got locum spend, you have things like that which are not necessarily contractually committed, but if we took them away, you would have a horrendous problem in terms of the way the service would look. So at the moment we're kind of looking at the areas where the resources aren't on the table and looking at that bit of it, and that will help then inform where we go out the back of a June monitoring round. However, none of it is without implication, and it certainly would all put us in a very difficult position. There's no doubt about that. The monies are most definitely needed to go to where they are supposed to.
Chair.
Thank you. Paul?
Thank you, Madam Chairman. You're very welcome to the committee. In terms of the bids that have been submitted and the prioritisation given to them, did the Minister sign off on this?
He did, yes.
Did the Minister change any of the priorities that officials had advised him? No. I think that's important because sometimes we can have a go at officials, but ultimately it's the Minister's priorities, and we can challenge the Minister, I think, on why he signs off on things in the way that they do. Officials will do as the Minister says, and that's the way it should be, and quite right. And for the record, I support the prioritisation, and I support the rationale that you've provided to the committee as to why the priority has been given to these bids that have been made. In terms of the contingency plans that Mr McCarthy touched on, you touched on them briefly. Obviously, the DFP paper suggested a potential £279 million worth of cuts if there was a 5.9% reduction applied to all departments in the absence of welfare reform being agreed, and that budget then having to be changed to deal with that reality. What would £279 million worth of cuts mean?
It's actually very difficult to contemplate how you would take 279 million of cuts out, in all honesty, in that you would be stopping elective care. You would have a silting up of the hospitals in terms of A&Es working through, because you wouldn't be able to provide domiciliary care packages out the other end. So you would end up with delayed discharges, which would back the hospitals up. I'm not even sure whether you would actually be able to do it physically, in that people would continue to arrive and continue to want or to need vital treatment. And as I was saying to Mr Easton, the issues around what can you actually control, you would be talking about taking out agency and locum, agency nurses, locum doctors, and that would have significant implications, particularly for smaller sites, because that's where a lot of that spend actually is. So you would be collapsing effectively into the bigger areas, hospitals, and even they would not be able to operate effectively. So it would be an exceptionally difficult and very difficult to contemplate what actually that would look like in the terms of the health service, particularly in a context where, even with what we've got here on the table, with a £30 to £40 million gap, a £279 million gap, is something that would just change the pattern of services completely.
Would it still be safe?
That would have to be looked at, but as I say, it would, because safety, and back to, I guess, Mr McKinney's point, it would be very difficult for doctors not to treat people, and how would, and you know, so I would any clinician or any professional find themselves in a place where they wouldn't treat a person who had turned up to get them into a safe place? Would somebody be left as a vulnerable person in their own home in a vulnerable state? I suspect it would lead to, therefore, safety remains, but we can't take the £279 million out. So, you know, the professional side of the equation, I would suspect, would mean that safety would have to continue to be there, and it would be very difficult for people therefore to live within the budgets they've got. You would end up with deficits, and you would end up with an overspend. I think that's certainly from the professional side,
yeah.
where it would end up.
In the realm of social care, I mean, safety is slightly different in that often you're working with situations where you accept there is risk all the time and you're trying to manage risk. What I would say under those circumstances is that the risk would rise dramatically. The risk to vulnerable adults living in the community, the risk to children requiring protection. You can never guarantee 100% safety in any of those circumstances. You manage risk, but under those circumstances I would envisage the risk changing very significantly.
Because obviously an overspend is something that you really can't do, and there's consequences to that if that's where we go. The £89 million, I think you'll do well to get a small fraction of it, if anything at all. So given that you've made a bid for £89 million and there is the uncertainty around the budget, even if the budget is put through based on welfare reform and we put it up, well, I say we, as in my party, puts it up to the Treasury and the British Government to intervene and legislate in welfare reform to make that a reality. At what point, though, and maybe officials aren't allowed, but is there a point in which officials make that political call that this isn't going to get sorted and potentially you are looking at serious cuts to your budget of £279 million or indeed more?
What you're weighing up there is effectively the role of the accounting officer versus the role of the political and the minister. For the moment, we could get the books to balance off the back of the budget that we've got by holding back on a range of commitments and with the consequences that I've already described. If out of the back of June monitoring we then don't get any further funds or not sufficient funds, then obviously the Minister would need to reflect on what that would mean looking ahead. As we've already debated, then a £279 million cut to our budget would put where we're currently at completely in a different place. And the role of the accounting officer is obviously to ensure that they live within the budget. You're absolutely right. You can, in the context of accounting officer, can ask for a ministerial direction to, if you like, say, well, what they would be doing is saying, well, I can't live within the resources I've got, you will have to direct me to do so. Ministerial directions, though, have to go to DFP, and that would come back to the fact that you don't have enough money to live within the resources you currently got. So you end up in a position whereby you can't actually overspend, which is the point that you're making. So particularly in somewhere like health and social care, getting those two things to actually match, particularly in the context of a £279 million cut, would be exceptionally challenging. But the accounting officer discussions with the Minister is where that gets resolved. And obviously DFP would have their concerns about that, and that's a different conversation obviously for them as to how they then deal with departments that are struggling to live within the resources that they've got. What I have done in answering previous questions is identify where money effectively is uncommitted at this point. But as I said, those all have implications in terms of if they don't go to where they were intended to go. And we need to then look out the back of June monitoring and work with the Minister around what priorities, if you like, he would want to reflect going forward.
Certainly, I don't envy you, and it does seem, from my point of view, quite a surreal conversation we're having about bidding for £89 million in the context of what we're looking at in terms of the financial realities of the failure of others to live up to their Stormont House agreement. Finally, from a purely parochial point of view, in terms of the capital projects, the co-location of the out of hours at Lagan Valley to the emergency department, and you may not be across this detail, it's just I didn't see it cited in terms of one of those schemes. I know that it's an ongoing piece of work to help facilitate the reopening of the 24 hours to provide that. I think it's around £1 million was the business case. Have you any update as to where that's at?
That one, because it's contractually committed, is in the ones that will go ahead, is going ahead, yes.
Thank you, Madam Chairman.
Okay, thank you. And Fergal was on this,
Just it's a smaller point, but still a significant point. It is conceivable, just on the NICE drugs, that some of those new NICE treatments that are now approved would be cheaper than the existing treatments. So what's your consideration there?
Absolutely, and you're right to point that out. If it's cheaper than what we've currently got, and that would actually, be able to be met. So what I was describing was a situation where the ones that have additional resource consequences with them. You're quite right. If it has no additional resource consequences, or indeed is a saving, we would expect those to continue to go through as normal. So what I'm describing is a difficulty where significant additional costs are incurred on new NICE drugs.
That's significant. There could be arguments in the margins there.
There could be arguments in the margins, but equally, that would be for the Commissioner to work through with the provider around what that looks like. But we certainly don't have significant funds to put into new NICE drugs looking ahead.
And just finally, how is that being communicated to clinicians and frontline?
We have had discussions with the regional board about it, and about the fact that we understand and realise that given the situation that we're in, that those new NICE drugs can't be funded. It's then for the Commissioner to liaise with the providers about, because they do that bit of it around what they commission from them, so that would be up to them to advise the Trust accordingly.
Okay,
Thank you. And Rosie?
Most of the issues have all been discussed here, but the £89 million bid, if you weren't to get that, what would it mean in real terms?
What it would mean is that we would, in its simplest terms, I guess, the waiting times would continue to increase and people wouldn't be able to be treated. It would mean that we wouldn't be able to put further investment into Transform Your Care on top of what we already planned. It would mean that we can't invest in children's services, mental health, new NICE drugs, and all the range of bids that we've currently got on the table. So effectively, it would mean a difficult scenario which would get worse through the currency of 15-16 rather than moving forward.
And is it possible to survive within that, or would you see that as walking you into crisis?
Well, where we need to ensure, as I've already pointed out, is that safety is the prime concern, and making sure that both patients and clients are safe, that they're treated within clinical priority order, that we make the best use of the resources that we currently have, and that's all part of it. What would happen, though, is that waiting times do continue to increase, and that will get more and more difficult for obviously both patients and doctors to deal with looking ahead. It certainly would put considerable pressure on the system. However, we still have 4.7 billion. We need to ensure that that money is used wisely and continue to be used wisely as we look ahead.
So if you got some of it, let's presume that you'll get some of the 89 million, would you cut each of the figureheads that you outlined, or would you maybe see some of them as such a priority that everything that you laid out, say for instance 23 million for one, that would be taken out of whatever you got, or would you sort of top slice everything and try and move everything along, let's say?
Well, that would be a decision for the Minister out of the back of GIN monitoring. I couldn't answer that in terms. I guess it would depend on the level of monies that he got. Certainly in terms of the existing service pressures, as I've already explained, we need to ensure that those things are continue to be supported, because if those aren't supported, then there's another implication further elsewhere in the system. So ultimately that would be for the Minister to decide, but he, in answer to previous questions, he has advised on these priorities. So I suspect he would wish to remain broadly in line with, but whether he would carve out some money to move it further down the piece, I don't know. That would be ultimately for him to decide.
Presumably you would recommend that you would continue in some shape or form to support each of those priorities.
Well, he, I'm sure, would wish us to ensure we can live within the funds that we have, and would absolutely be ensuring that that is the case. And that means we need to deal with existing service pressures presenting first, before we would then to turn to the rest. But equally, I know he that all of those areas he would wish to support if he could, but it will depend on what level of resource he was given, and therefore how he wants to move that ahead, and it will be fundamentally up to him to make that decision.
You see what you consider to present the greatest risk at a given time. We know that there are some conditions that if they're dealt with early, they will then not become a risk at a later stage because of an intervention. Do you look at that in terms of how you work it out, or do you just deal with current pressures as they arise? I'm talking about you've got all of the big risks like diabetes and obesity and all of the issues that can be serious in some degree or other, but at a point further down the road you know that they could be fatal. So do you take that into account, or do you just say, here is the current priority just today?
Well, you're trying as best you can to look at both, and we do have a public health bid that is at £4 million, which is within that first tranche. It can be very challenging to do that because, as you say, the demands are presenting on an ongoing basis, and therefore putting money into that preventative piece is a difficulty. Having said that, looking at how we deal with the likes of diabetes and obesity and that sort of thing, that's where the likes of Transforming Your Care would want, if you like, us to move forward or propose that is the case. And there's a diabetes bid within that as well that would hopefully allow that to happen. So you're trying, if you like, to bring all of that together, and it's wrong to say that we're not doing anything in public health. We most definitely are. I mean, the PHA would have resources of over £90 million to, if you like, within that public health space, never mind the preventative work that clinicians and GPs would be doing on an ongoing basis. But the bids are a mixture of dealing with the here and now, such as the unscheduled care and patient flow bit, and the future, which is the public health bid. And we've tried, if you like, to ensure that we are reflecting all of that within the bids that we put forward. But you're also talking about the use of the money that we've already got and ensuring that is happening. And Minister, obviously, who wants us to continue to reform the service and to move things forward, and ensuring that preventative piece and our lifestyles and all of that, if you like, because if we can crack that particular problem or move it or improve it, then that would help considerably. But it may take many years before you see the benefit of that. So they're both there.
It's also worth noting, I mean, certainly what we're looking at is a very challenging scenario, but we've been in a very challenging scenario. And in that difficult time, unfortunately, we didn't get time to reference these points when we were talking about our programme for government commitments, but we have made very significant progress, and they're reflected in our programme for government commitments in relation to increasing the amount of investment into public health, specifically increasing the amount of investment that's going to obesity prevention programmes, also investing significantly in the very sort of issue that I think you've been referring to, chronic condition management programs, where you're attempting to assist people to be able to manage their condition before it becomes more acute. And I mean, if you would like to look at the material we supplied under the programme for government achievements, you'll see that we have, through a very difficult period, nonetheless continued to invest in that activity, and we've achieved our targets in that very successfully. So it is a balance, it is very difficult, but as Julie says, it's trying to deal with the immediate acute need that you have to respond to when it's in front of you, while at the same time trying to hold on to investing in those longer term preventative measures. And so the programme for government picture, beyond the discussion we had, actually reflects great progress in that area.
Thank you. Thank you. Just a couple of points to clarify before we finish here. The 2.5 million under the prioritised service developments, which is under other departmental priorities, what are they?
2.5 million includes, I can just turn to it. It includes training provision for education and training, £1 million. That would allow some additional education and training. It would also support the General Dental Council recommendations, which are about training of dentists and making sure that they get more training in a community setting so that they can deal with more patients in a community setting. There's also £1 million in there for the development of a range of non-specialist acute services, and that includes the delivery of more programmes for long-term conditions. It includes some work around early identification of patients, so that in terms of palliative and end-of-life care, so that they can get earlier support, so that they can have wraparound services. It also includes money for the commissioning of a community pulmonary fibrosis service and a community non-invasive ventilation service. And other pressures then are in and around, back to some of the sort of the inspection and safety work, in and around additional health and social care inspectors, for example. But in terms of some of those bids, the ones that I mentioned in terms of the specialist acute services, you know, all of those again are being bid for under other departmental priorities in terms of those particular issues, and yet, you know, they are TYC consistent, if you like, but they're not being bid for under transitional TYC funding as part of the 5 million. So again, it's just, you know, and we do this because of how the funds are managed, if you like, in terms of different programmes of care and so on. But it's just, you know, again, that's another £1 million, which is consistent with TYC.
Okay, and in terms of just, and again, clarity on this, just yes or no, or, you know, the 5.5% reduction in the fire service budget, what kind of analysis has been done on the impact risk on the service?
We are awaiting receipt of their final savings plan, which we understand is going to be coming to us very shortly. They have absolutely been looking at managing risk, and that's what you would expect them to do. They have a risk management plan that they have that they operate by, and we and they would, again, back to the safety issue, would mean that firefighter and public safety is the absolute priority. So risks will be considered, identified and then managed as they implement those savings plans.
But you must have a view at this point that the 4 million reduction
what they're
present
saying,
a risk.
What they're saying is they will look at the risks and manage those risks, and that firefighter and public safety will be their absolute priority. That's what they're saying to us as they implement those plans.
And so there is a risk, obviously.
Well, in the same way as there's a risk in any service change, what they're saying though is that risks will be managed and that public and firefighter safety is the priority.
And just finally, Julie, the 16 million savings. One person's saving is another person's cut, but on departmental running costs, is there a split? You talk about admin and programmes, which is it, or is it both, or on that there's an element of both. So it's departmental resources that 16 million is coming off. We obviously have administration for our own internal department, and just over 1 million, if I can recall the numbers, is of that 16 million is coming from our own department, having to live within a reduced level. And then the remainder is looking at our programme budgets and trying to identify, well, what could we reduce within that. And the problem, of course, with all of these things is absolutely savings are a challenge. But if we don't achieve those savings, then the position becomes even worse out the other side. So 16 million has been worked through on the 1 million admin and 15 programme budget.
Yeah.
Can you furnish the committee with that list of...
I'm sure we can get a yes if you first right.
Okay, listen folks, thank you for your time today. Appreciate that clarity and clarification. Obviously there's a number of issues that we want to be reflecting on. Thank you. Okay, members, item 6 is an SL1, the optical charges and payments regulations 2015. It's page 87 of your meeting pack, and it's the department is proposing to make a statutory rule to increase the value of optical vouchers issued to certain patients to help towards the cost of glasses or contact lenses on the health service. The rule will be subject to negative resolution procedure. Are members content that the department makes the statutory rule?
Yep.
Great.
And item 7 is the forward work programme, which is at page 96. I'm asking members to note unless there are any issues. Item 8, matters arising. There are 4 items under matters arising at page 60 of the meeting folder. Page 99 is the response, item 8.1, is the response from the Minister in relation to the committee's request to have the BMA included in the membership of the unscheduled care task group. The Minister has indicated that the request will be considered as part of the group's forward planning exercise, which is currently underway. So I'm just seeking agreement to forward that response to the BMA for information. Page 100 is a response from the Minister in relation to future shift left, linked to the conversations we've just had.
Just
yes,
one point, Chair. I mean, the Minister has said there it has not been possible to identify funds for significant new service, including those that would support further shift left. Yet we heard here that there was a 16 million figure pencilled in this year out of existing resource and not June monitoring. To make the point.
Yeah, I mean, and the point's well made, and the Minister has indicated, you're right, in the letter, that any further shift left in service, again, would be dependent on funding becoming available through monitoring rounds, which is the very conversation that we're having, and also confirmed that there was no intention to change the status of either the TYC Transformational Programme Board or the TYC Central Programme Team. I'm suggesting members we write back to the Department on this for clarity, a detailed explanation of why any further shift left is dependent on funding through monitoring, the reason why funding to meet the aims of Transformation Your Care was not provided for in the mainstream budget, and thirdly, the membership of the board and I think the Central Programme Team, and information on the connection between the two bodies and structures. Page 102 is a letter from the Minister in relation to the Food Hygiene Rating Bill, and the Minister has outlined changes suggested by the Attorney-General and the Minister for Justice to Amendment 36 and has provided the wording of the redrafted amendment. This relates obviously to the committee's proposed amendments to Clause 7, which would require the issue of businesses supplying food by means of an online facility to ensure that the establishment of food hygiene rating is provided online. Members, just given that the redrafting of the amendment is purely of a technical nature, I don't think there's any issue. It doesn't change the intent of our amendment. I'm asking members then if they're content to note. I think it's simply technical.
Chair, can I
Yes.
just jump back? I'm sorry I didn't think of this point earlier on, but it just occurs to me, given what you're saying about writing to the board, is it appropriate for the board chair or the board chief executive to be running the TYC programme as well, given that there would be some accountability mechanisms there that would be then missing as a result of that?
I think we should include that question, absolutely. Yeah. Okay. So are members content with the remainder of matters arising? Item 9 is correspondence. 7 items at page 105 of the meeting folder. Again, I just want to draw your attention to a number of them. Page 106 is correspondence from the Minister providing a copy of the implementation plan for the recommendations contained in the Marshall report. Seeking agreement members to request a written progress update from the Department in the autumn. Agreed?
Agreed.
Page 139 is correspondence from an individual in relation to the law on psychoactive substances. The Minister had issued a memo round members today, given that there is draft legislation now in England in place to look at a general ban. I'm seeking agreement, members, given the importance of this issue, that firstly we would invite the individual to the next committee stakeholder event, and that we would also write to the Department for details on what consideration they're given now, given that announcement last week, to introduce a similar ban here in the North. Agreement to just note remain in correspondence unless members have any comments.
Just to pass comment on on 138 in you're picking up. Reference the thanks from the ME support for our stakeholders.
Yes.
It's a contradiction in terms from the other one from somebody who was it, kinship people.
No, well, I think it's useful. Certainly, we get feedback, and it's particularly useful that organisations gain something from the experience. So it's well noted. Okay, members. Any other business? Do members have any other business? And 11 date, time and place of next meeting is Wednesday the 10th of June at 2 p.m. in room 30, and there will be a pre-meeting at 1:45. Thank you, members. There we go.